facilitated that has low prevalence or low number of high number of unmet needs, and then they prioritize those two provinces. And then when they prioritized those two provinces, then there was in-country engagement with implementing partners. And then all those implementing partners will be able to identify what are the reasons why there's no uptake of female circumcision in those facilities. Some of the reasons were that there was no demand creation, so they had to work to ensure demand creation, ensure that the quality of service that were being provided to clients were of a very high was a high level service also. Good quality service being provided to them. So they did what they call the quality assurance visits to all those facilities to ensure that everything was being put in place to ensure that the clients, when they leave the facility, they will be satisfied. So in a nutshell, what from math model to policy, first of all, one has to engage the stakeholder early and very often, because they have to be at the end of the day on what is being done in their country. They also design the model and having a simple user interface so that they are able to navigate through the model. Like the one I just mentioned here, which is the decision maker program planning toolkit for male circumcision. It's a very massive Excel tool that you give to many people who are not really Excel savvy. They may not be able to know how to navigate through that tool. So by designing something that they will put online and with a structured user guide, it became easy for people in country to just go and extract the result that they need, because the data is already populated in the tool and the data is updated on a yearly basis. Also, the model need to know the country, and that's the reason why you need to engage the stakeholders to understand what is their need and also tailor the result based on the country's need. Also, you have to plan for sustainability, because if you develop something and just dump it on people in the country, then it may just be a one-time thing. But what happens after you leave, when you have developed this and discussed with them? So one need to plan for sustainability, and this is generally done through regular refresher trainings and updates, and also facilitate dialogue around the tool integration into policy. You have a 2 or 3 year or 5 years funding for a project, but if you ensure that you facilitate that dialogue around the tool integration into the policy making process, even after the project ends, then the country will be able to use the tool to move their policy process. So in the kind of recommendation, we identify 6 pillars for success, from moving from a mathematical model to ensuring that influence policies in countries. So the first one is to identify and engage a wide array of stakeholders who are involved in the program of interest. And through this process, one also has to identify who are actually the influencers or the champions in the country. Because you cannot communicate with everybody and expect everybody to respond to all your emails. You have to identify somebody who is very motivated, and then try to have that person like a point of contact, go to that person to be able to assemble all the stakeholders in the country. The second point is to ensure understanding of the value of modeling. It is generally very difficult to explain, especially complicated mathematical equations to lay readers. So it's very important for the person conducting the modeling to be able to speak in a language that policymakers in the country will be able to hear, to understand and follow. Also, one has to identify and agree with such a question. Because if you design the research question on your own and you don't interact with the people who will be using it, at the end of the day, it will just be another document that is just being sent to them, but they are not really part of the process. The fourth one is to identify and agree also on the input variables, and that's by tailoring, that's part of tailoring the model to their own needs. You have them what exactly they want, and based on what they want, you have the data, what are the assumptions to be made. And all these assumptions made have to also be channeled to them so that they are part of the process. You don't stick on your own as a model and decide of what the assumption should be, because sometimes the assumption A country X is not the same thing that country you would like to see. So, because it's country specific, they may say, oh, in our country this is something that we already do, so can we also, consider this? The fifth one is to identify, the sixth one, the last one, is that after completing the model, we have to come together to review the result and agree on the policy. And this is basically the dissemination of the result with the country stakeholders. The model needs to present this result to them so that they are comfortable with the result that comes out of the model. So these are the 6 pillars that we identify that if you have a country and study, then if you follow this, we think that if one follows this process, whether it's a modeling or another study, then you'll be able to get the buy-in of stakeholder in the country who will really be able to, at the end of the day, own the result that will come out of the study. And then we have different. And from we published the second one there, which is using mathematical modeling to inform health policy. It's a +1 article. So basically, this is what I have for you people. I think more people are writing in the chat box. There are some things on coming. If you have a question, you can ask, or I'm also available to answer questions by email, separately if you contact me. Thank you.
Let's put our hands together once again. I know we have lunch, I don't know if we can, but we can do better. That's the first presentation we had after lunch. So put your hands together once again for Professor. Alright, we're going now to our abstract presentation, and we have about 12 presenters here. We have 5 that will be presented virtually. Yes, we'll take them as they come. But we have rules as well. We'd like everyone to stick to just 5 minutes. 5 minutes, please, so we can keep the audience interested. I think if we decide to have this presentation within 2 hours, we'll have it. So now we have the room still full. I'm really excited. Let me just start off by saying thank you very much to everyone who has been patient and who's still in the hall with us. Thank you. This really means a lot to us. I'd like to also recognize the presence of our guests who have been here with us. Thank you for staying put. We're hoping that we'll not take much of your time. It's Friday, the doors are in Lagos with traffic. So we'll do this and make it as interesting as possible. And if you have our questions, please let us know so we can get the questions and get the answers out. But for our virtual presenters, we will not have time to ask them questions because I do not think we can hear us as well. All right, I'd like to call on Dr. Adejumi for his presentation. Please put your hands together. Dr. Adejumi is going to set the tone for us to show us how it's done in 5 minutes. Watch and see.
Let us know the existing protocol. I want to, this is one of the study, not to study anyway, but we have records. I'm Dr. Adejumi from case management, one of the leaders in the US courts. And I have my colleague, Dr. I'm forgetting your name. All right, we had well, earlier on in the response, we had people admitted into mainland hospital and all our facilities. We now discovered that some people came in and were admitted or treated and were negative, and some were positive and were treated as well. So when we were playing there, we just decided to look at what are those clinical features of those who are negative and those who are positive. Maybe there's some striking characteristics of these COVID positive patients that were treated in all our isolation center. So the next one. Location was Lagos. It's a metropolitan body, just like I said. We use classification, NCDC classification for COVID-19 that classify patients into mild, moderate, severe, and critical. But we use the one by NCDC that classify patients into mild and severe because of some of the variables we have fitted to that. Then these factors for severe diseases, WHO guideline says that those who are aged above 60 and those that have some of non-communicable disease like hypertension, diabetes, cardiac diseases, chronic lung diseases, cardiovascular disease, chronic kidney disease, and immunosuppression, cancer, and smoking. Those are those characteristics that can push patients to having severe form of the disease. These are the statistical tests that was used for the work that we did. We used tests to compare numerical values. Next slide, let's go to what we found. That's our findings. We admitted the norm. Actually, the study period is between when the pandemic started, February 27 to the end of September. That's the period when we collected the data. So in all, we have about 370 patients admitted in all our 15 isolation centers, and out of which about 90.2% tested positive. And the next slide. Now, in terms of presentation as well, apart from loss of taste and loss of smell, a higher proportion of those who are COVID negative have fever, cough, breathlessness, weakness, and all other signs and symptoms that is usually peculiar to COVID. Next slide. Now, in conclusion, if you look at this, you can see that there's actually, we have even more people having comorbidity and having some of these symptoms that came out COVID negative, that were COVID negative. So what that one tells us is that laboratory diagnosis remain key in identifying COVID-19 patients, and also the volume of testing and the turnaround time of laboratory results are crucial in the control of the pandemic. Thank you. Yes, sorry, I have another abstract. Well, this one we're looking at trend in mortality because we know it's a response that spans months now. So we're looking at what is the trend like in terms of mortality and what are the factors that we get among COVID positive patients. Next slide. So I'll just go straight to the results, no room for formalities. Next slide, please. Next slide. No, that one. How do we take this time out of my time? Next one. Okay, thank you. So these are the results. Now we took samples. We have about 50 isolation centers in Lagos, and that's the distribution of some of the patients treated in each of those isolation centers. So in all, we have about 2,858 confirmed patients treated in our isolation center between this study period. And of these, we have those who were managed in the public sector about 95.6 and the private sector about 4.4. Mean age of our patient was 41.9. And the age range was between 3 months and 98 years. Next slide, please. Well, that is the age distribution. Okay, this is the age distribution. You see that we have more people who are between 30 and 39, and let's say that between 30 and 49 years. So this is the age distribution of patients treated in all the isolation centers. Next slide. Now, we found out that we have more males admitted. About 2/3 of patients are male, and symptomatic patients are about 51.4%. Those with comorbidities they are about 27.8%, and mild cases were 73%. So we only have about a quarter, that's 26.3% with severe presentation. Of those mild cases, a higher proportion of them, that's 64.1%, were symptomatic. the mortality rate in this pandemic that we have in our isolation centers is about 6.5%. Next slide. Now, this is the mean length of stay. Averagely, patients stayed about 12 days on an isolation center before discharge. The mean length of hospital stay was longer in patients with no risk factors than those that presented with risk factors. It's also longer in those who are mild cases compared to severe cases. It's longer in those that survived. Those that survived they spent about 13 days in isolation, whereas those that died, it took them 2 days who survived. The length of hospital stay reduced with advancing age. That the older the person is, the more likely they stay in the isolation center. It also increased with the presenting symptoms and also increasing number of risk factors. Next slide. Now, this is the trend. When we started this response, sometimes in February, last week in February, that's February 27th, there were no deaths until the last week in March. And it progressed and peaked at last week in between last week in June and May and the first week in June. So the peak was actually the first week in June. Then thereafter, there was a decline in the number of deaths that we experienced during this pandemic.
1 minute more.
Yeah, next slide. Now these are the number of admissions. Next slide. Now, what are those risk factors associated with mortality? We found out that mortality with increasing age. If you look at this slide, you find that the age-specific mortality with advancing age. Also, male, we have more deaths among males than female. There were more deaths among those that had symptoms, and the number of symptoms is also crucial. The more the symptoms, the higher the death rate. Next slide. It's also higher among those who have comorbidity, and it's also depending on the number of comorbid conditions. So when you look at those who presented with symptoms, both symptoms and comorbidity is much more higher amongst them. In terms of disease severity, it's higher among those that have severe presentation. Next slide. Now, regression analysis, just to know what are age for each age each day we have about 4% chance of having recording or having a mortality, keep advancing age. Also, we find that for the males compared to the female, they have about 50% chance more of us having mortality among the males than the females. Also, those that presented with both symptoms and comorbid conditions, they have about 2.8 chance of dying, and those that have severe disease have about 15-fold chance of dying compared to those that have mild disease. This is about my last slide. Next slide. All right, when you look at some of those risk factors that we talked about, those who have diabetes, those who have immunosuppression, and those who have cancer, they have higher chance of dying compared to those who don't have some of those comorbid conditions. Last slide. Thank you very much.
Once again for Dr. I'd like to call on Professor Tangwa, but that's if he is online. Do we have Professor Tangwa ready, please? So Professor Tangwa is standing by for his presentation. Alright, so while we try to get Professor Tangwa online, is he ready? presentation, please. And because we have Professor Sancho, Mr. Chipola will. Is there a problem? Please put your hands together for Mr. Chipola. Please come up for your presentation.
Good afternoon, everyone. Standing on the system protocol, I'm presenting a performance assessment of selected RT-PCR kits for the detection of SARS-CoV-2 at Lagos State Power Plant in Lagos. As rightly said by Dr. Wadeju, diagnosis remains one of the most important tools that is used to curb the spread of any disease. Please, next slide. Alright, these are the introduction, signal of problem, and all that. The disease COVID-19, which happens to be a severe acute respiratory syndrome, SARS-CoV-2, which emerged in late 2019 in China, has gone to spread all over the world. Next slide, and we can see the mortality rate and what has happened. Here, what we are trying to say is that if a patient is easily diagnosed and diagnosed early enough, then all the measures that needed to be taken to prevent the spread of the disease in the community will be quickly taken, and a curb to the spread will be achieved. Next slide, please. So we have different types of diagnostic tools that can be used, but we are staying with RT-PCR. Next one. Please, next one. We have target genes for some of these things, what we do in the lab for PCR. And now, let's look at the problem that we're looking at. Among the commercially available kits that is developed for the diagnosis of SARS-CoV-2, the problem of specificity and sensitivity have repeatedly been a growing concern in detecting the presence or absence of the SARS-CoV-2 and in samples that are sent to the laboratory. And on the next slide, please. So our aim is to investigate and compare the diagnostic performance of 3 selected commercially available RT-PCR kits that are brought down to the lab, and our objective is to evaluate the clinical sensitivity of the kits, to investigate clinical specificity of the kits, and also to determine the false negativity rate of the kits. Next slide, please. So the normal methods that are done are the kits, availability of the kits in the lab, accessible information. Some of the kits comes in languages that you cannot even read or that for us here. Compatibility with different real-time PCR systems, the common detectable genes, and also presence of endogenous internal control, which is very, very important. Next slide. So, the selected commercially available PCR kits that were selected were Danji, Sanshot, and then the BGI. Next slide, please. So, please, next one. So, the samples, nasopharyngeal swab, and also Sputu were brought to the lab, and these were processed to isolate RNA, which is now then turned for PCR. Next slide. So, all generated CT values were processed using the results, the normal statistical tools for doing the normal. Next slide, please. Now, let's look at the results. These are the results that were generated from the 3 selected PCR kits. We can see the sensitivity of the first one, Danji, Sanshot, and the BGI. Danji has a sensitivity ratio or percentage of 34.69, while Sanshot has 89.80, and BGI 40.82%. And the specificity Of each of those kits, we have for Danji was almost 100. For the 3 of them were 100. But what's so interesting is the negative predictive value, or the first negative rate, which we have for Danji to be 65.31, Sancho which is 10.2, and also for BGI, which is 59.18. All these results matters a lot in the choice of kits that is going to be used to get a very good result. Next slide, please. And this is the rock graph. We can see for Danji, that's sensitivity against specificity. We can see for sensitivity for Danji, close to 40. For Sancho, more than 80. And also for BGI, we have almost close to 40. Next slide, please. So this is a combination of the 3 kits. And then we are looking at, we can see the area under the curve for each of them. Sancho has the highest. That's the red one, from up down. While followed by BGI, the blue, and also Danji for green downward. Next slide, please. So, this is the careless comparison of the criteria for each of the kits. And we can see the results of them and the confidence interval for each one of them. Another, next one. Okay. In conclusion, after looking at and comparing these 3 kits without any conflict of interest of anything, Sancho has proven to be the best kit in performance, both in sensitivity and specificity for SARS-CoV-2 COVID-19. Although the other 2 kits are also not doing badly, but Sancho ranked highest among the 3 of them. Next slide. These are references. Thank you so much.
Thank you very much. Everyone for the job, thank you so much. And so we have Professor Kangwa now. I believe he's ready. After Professor Kangwa's presentation, we'll take a couple of questions. So if you have questions for the first presentations, please write them down and let's indicate by raising your hands. So we'll take your questions when it's time. We'll take Professor Kangwa's presentation now.
Hello? Yeah, hello? Okay. The title of my essay is From HIV/AIDS Through Ebola to COVID-19, The Unlearned Lessons from Recent Epidemics in Africa. So I start with a lesson that I think has been learned, which was created in August 2014 at the height of the West African Ebola epidemic, which raged from 2013 to 2016, was an attempt by indigenous African experts from several relevant specializations in collaboration with interested foreign counterparts to mount a holistic response to an emerging infectious disease, drawing lessons from past epidemics where they have watched foreign experts, capital, and interest take complete charge and command the situation. So part of the work of the GATE Consortium is captured in the following publication. The title of the in the response is ineffective, permanent which away, and transit in stop. Six. Can't hear me. Have I been unmuted? Not that so. Can you hear me now? Oh God. Okay. If you can hear me now. Okay, so I will continue. Now, I've talked about I take learned lesson. And the first unlearned lesson is that a locally grounded indigenous outfit against emerging infectious diseases and bioinsecurity in the African context, for it to be effective, it must be accompanied by adoption of a strong new existential guide, including mental decolonization, self-reliance, rejection of all forms of colonial hegemony and unjustified dependency, to replace the current dominant paradigm, which is based on exploitation, colonial hegemony, and the attempt to impose a global monoculture through scientific myths and apparent philanthropy. Seeming philanthropy. I go quickly to the second learned lesson. Biodiversity is an important human and environmental value, and some of the emerging health risks the world is facing are directly related to the destruction of biodiversity through the increasing production and use of artificial systems, devices, and monocultures, which are highly profitable for their inventors. Third unlearned lesson. All recent deadly infectious epidemics, notably COVID-19, whether they are of natural or artificial origin, have been present on the African but they have failed to wipe out its whole population in the way that prior informed objective calculation would indicate, given general public, dangerous habits and practices, and lack of medical facilities. This situation is likely due to biodiversity and living relatively close to nature and far from artificiality. I go to my conclusion, and these are the provisional conclusions that I have drawn. Perhaps the greatest learned lesson is that the pandemics we have experienced in recent times and are experiencing and maybe experiencing in future are the result and concept of the artificial aspect of our exosomatic evolution, epitomized artificial intelligence and machine learning, that the world has since the West Industrial Revolution. But exosomatic evolution and artificiality have clearly reached their logical limits, and insisting on pushing them any further will push mankind over an evolutionary precipice. Reversing the trend is more important than finding a path, let alone assuring peaceable access to any vaccine for any of our pandemics. COVID-19 in particular seems to be an epidemic, particularly lethal for artificially built up areas from where nature has been banished by modern technology. If we observe where COVID-19 has been very lethal, and we observe carefully the situation in Africa and the areas in Africa where it is devastating, we will think that this is a conclusion and a hypothesis that stands to reason and that needs investigation. We need to get closer to nature. We need to abandon exosomatic evolution and artificiality. There should be no where the top is taller than the tree. So that I can end my presentation. Thank you very much.
Thank you very much, Professor Atangwa, for your presentation. Put your hands together again for Atangwa. I'd like to know if Dr. Helen Adamu is ready. Is she? That's another virtual presentation. Can we take another one? While we try to set up.
Yes, I think I'm ready now. Hello. Good evening, everyone.
Good evening.
Okay. So I want to walk us through my presentation. The antimicrobial. Sorry, my name is Dr. Harry Adamu. A staff of Georgetown University. I want presenting on the antimicrobial resistant pattern across 2 states, a descriptive observational study. This study was done as part of the surveillance and epidemic response grant that was provided by USCDC to Georgetown University and the Center for Healthcare and Research in Nigeria to strengthen surveillance at NCDC. Am I audible? As part of health assessment, we visited several facilities at two states in Lagos and Abuja. We had we reviewed facilities, the laboratory units at the health facilities. The facilities visited were health facilities and one central G, and in F6, one public health facilities and one private health facility. That's taking a total of 5 facilities that were assessed for this study. We used Excel-based templates to collect data from those facilities. The goal was to assess their antimicrobial resistant patterns for common pathogens that were occurring in these 2 states. The focus of especially their some towards the region, but just to give a clear picture of what is happening in the country. So, first we evaluated the laboratory units we looked at using the WHO assessment and criteria. We looked at their equipment, their calibration, the human personnel. We looked across a range of criteria just to assess if these facilities were capable of being included in the network of labs that will be submitting data towards the antimicrobial resistance area. So, for the purpose of this study, like I said, we settled on 5 laboratories, 2 in 3 in Lagos and 2 in FCT. And we used Excel-based templates to pull out the records. That's the laboratory records from their labs. The patients normally visit the lab for antimicrobial resistance test, and these records are included. So we blinded the section for the identifying information and just collected specific data like the age, the sensitivity, resistance, antigen patterns, and all this information was in, which is 25.2%. And this was put on. The age category, we have more of the adult Klebsiella species, which is made up 40% of negative isolates, most positive from our study. So a breakdown of frequency of bacteria from the specimens collected. We had more of urine samples collected, like 52 samples that yielded positive isolates. We had of these 52 samples, we had like 35% of them which were certified. And we had vaginal swab collected. We have more of polyphone species, which were like 50%. Something that was a gap that we noticed was that what was in the record books, it did not indicate what source of specimen, whether it was semen, urine was not indicated, and this made up a major block of the isolates that were found. Those that were not indicated stood at 46.9% for Staphylococcus aureus. Going on to the distribution of bacterial isolates by gender and location, we have what we found was on Staphylococcus aureus, just a reiteration that in females we have more Staphylococcus aureus, followed by E. coli. By location, we have facilities. And both gender, that's males and females, were equally affected for Staphylococcus aureus, followed by Klebsiella species. And one of the things we found was that the multi-drug resistance pattern come for majority of the pathogens, which 3% of those isolated bacterial pathogens were found among uropathogens. We found maximum resistance observed among first-line antimicrobials, that includes cotrimoxazole, tetracycline, second-generation antimicrobials were also affected, including third-generation antimicrobials. So these are the maximum resistance profile that we have studied. Staphylococcus aureus was imposed to multi-drug resistant pattern across all antibiotics, followed by the Klebsiella species. The least resistant or highest resistant formed allylic acid and amoxicillin. What we have concluded from this study was that there should be increased there should be increased in-house surveillance across prevention and control across antimicrobial resistance patterns across the country, and the works and activities of laboratories should be monitored closely to ensure that they meet set criteria, a minimum bar for sensitivity and animal testing across the country. Because this data feeds into national data, it's expected that this data will meet their quality test. So there is a need for control. That is my conclusion. Thank you.
Thank you very much, Dr. Nadamu. I'd like to call on Adebuke Amodu for a presentation, please. Adebuke Amodu, please put your hands together for her. I'd like to call please pardon us. Those who are projecting virtually cannot hear us properly, and that's why they seem to overrun. Communication is not really going very clear in that area. But we'd like every person to please stick to time. It's 5 minutes.
Okay. Thank you. That is my presentation.
Apologize.
Of 6,002 rapid IgG combined antibodies at every from finger to next. I would like. No, this is my outline. Next slide. Next. As a way of introduction, SARS-CoV-2 is the positive agent of novel infectious respiratory tract disease, popularly known as COVID-19. Globally, the adopted method of testing as the gold standard is RT-PCR. But looking critically at this RT-PCR, we find out that it has its limitation, as it's very expensive, laborious, requires some degree of expertise, and the results are returned not heavy enough. Considering the impact of this pandemic and the rapid spread of the infection, there is need to develop a rapid test protocol to further carry out the investigation, to further detect the positive agents. We find out that there are some point of care tests available which specifically detect IgG/IgM. So to this end, we decided to conduct a study, a prospective observational study, to evaluate the performance of these point of care tests. Next slide. Our aim is to evaluate the performance of 6 point of care tests. And to achieve this, we have to evaluate next slide. We have to evaluate sensitivity and specificity. And finally, to determine particular point of care tests that meet up with the test of accreditation. Next slide. What problem are we facing that made us decide that we should look for another alternative testing method? Considering the population of Lagos State, which is a mega city, there is need to test more people to actually curb the onward spread of the infection. But holding on to just RT-PCR, which is the gold standard, will not allow us to get desired percentage of our population tested. So to this, we need to develop a rapid test protocol to ensure that desired percentage of our population are tested. Next slide. The methods adopted in our study. We 450 participants were enrolled. Their consent was secured, and the consent form were interpreted in our local language. The samples taken for RT-PCR were oropharyngeal swab, nasopharyngeal swab, and sputum specimen, all combined as one for the analysis. For point of care test, that's rapid test kits, we collected capillary whole blood from the fingertip at a different time point after the onset of the disease symptoms. Then specificity and sensitivity compared with the gold standard were calculated. Data method used were AUC, DOR, positive and negative predictive value, sensitivity, and specificity. Next slide.
Hello.
From this table, we can see that specificity range from 58.16 to 18.17, while sensitivity ranges from 30.77 to 61.36. This is still not up to standard to say that tests can be used. Then what is striking mostly in this table is false negative results. If you look at the table, you find that most of the kits return almost 50% false negative. The implication is we have more people in our community working about with the infection under the pretense of testing negative. Next slide.
We have this 1 minute.
To this end, we were able to infer that none of the 6 point of care tests evaluated was able to be specific enough to detect the causative agents. Although they are very cheap, easy to carry out, with fantastic turnaround time, but they failed test of accreditation as they fell below the required standard and reference value of the statistical tools adopted. Thank you.
So far, ending at exactly 5 minutes. Put your hands together once again for her. That was just amazing. I'd like to make a quick announcement. Thank you. She deserves an applause. Thank you so much. Thank you very, very much. I will have a quick announcement to make. Please check your tables and check your bags. Someone is searching for a black flash drive. It has so much information in there. It's possible a switch took place maybe the person was trying to submit their presentation on the IT desk. This person is about to travel and has so much information. So if you have a black flash drive and you cannot explain how that flash drive got into your hand, your table, your bag, whatever, please let us know so we can return it to the owner. This this person is in dire need of all the information in that flash drive. Just check your flash drive as well. You might think you have the right flash drive. You might think you also have a black flash drive that's yours. Put it into your system and just verify. It may not be yours. Yes. Please do that and return. Ladies and gentlemen, please join me to welcome Cconference for his presentation. Her presentation, apologies. Sorry. Cconference, please put your hands together. She's about to give us another 5-minute presentation. She's about to show us how it's done. Yes. I'm looking forward to this. I have a feeling she's going to get it in 4 minutes. I see that happening. Please, can we have some quiet behind, please? One house, thank you.
Good afternoon, everybody. I am Dr. Cconference, the Executive Secretary of the Blood Transfusion Service. I'll be talking about COVID-19 pandemic and its effects and mitigation actions on the Lagos State Blood Transfusion Services. So, next slide. So, Lagos State Blood Transfusion Service was created in 2004 by law to provide safe blood for the state. And the Lagos State Blood Transfusion Service coordinates activities between its agency, governmental or non-governmental organizations, the government itself, and potential donors. So this study describes the effect of the pandemic, as I said earlier. Next slide. So these studies form part of the quality improvement exercise we do regularly. Quality improvement exercise comes every quarter at the agency. It's a qualitative design through conducting 10 key format interviews. So we had 10 of our partners coming together to conduct this interview at 4 different times. We also had meeting sessions with the staffs and the partner organizations as in form of stakeholder gatherings. All the data collated were analyzed over the review period. Next slide. So the effects of COVID pandemic were actually of two folds. We had the anticipated effects and what we actually met when it started. So we anticipated that once the pandemic kicks in, we will cancel all advocacy meetings and we'll cancel all launch donation drives. We anticipated a lockdown and that there will be limitation of movement for both donors and for staff. We also anticipated the fear of COVID-19 because, as we all know, it's a novel virus and we were not sure of the safety of our volunteers, of our donors, and of the staff. Immediately the pandemic kicked in, we noticed something. And was unexpected turnout of events because the voluntary donors converted to commercial blood donors, and we know why. Business was low, there was no funds for them to meet up with their present needs. Next. So, I said talk about mitigation actions with pictures. So, if you look at the first slide on the left, we increased our voluntary blood donation drives before the pandemic kicked in. So, we could do this because we had good leadership. The Honorable Commissioner of Health made sure that we had our plans in place before the worst of effects of the virus came up, of the pandemic came up. So we increased our voluntary donor drives. That's one of our drives. We had a lot of people coming in. Usually we make our drives come in at particular times so that blood does not waste. If you you look at the second picture on the left, upper right, we had a lot of advocacy drives. We met with youth. An example is the National Youth Corps, Service Corps members. We had to go to them, they gave us a lot of blood. They went out to also talk to other people to donate blood so that there will be more blood than the blood banks. Then we increased our advocacy by talking about safety of COVID-19 and blood donation. Because there was a lot of fear, as I said before, we anticipated this. And then we encouraged all general hospitals to begin to organize their own voluntary blood donor drives because we were sure that people would not be able to donate blood thereafter. Next slide. We also, because we needed to make sure that a lot of blood products were available, we made blood products from every unit of blood, more like 95% of the blood that was donated. Because initially it was every unit of blood. After we had a lot of packed cells, we had to begin with all blood donation. So in getting to do that, we had to train more staffs. Just a few of the staffs were trained in the use of the cold centrifuge. So in anticipation of inability to have components, we trained more of the staffs. Then we extended our hours of work. Usually the voluntary blood donation service works between 9 a.m. and 3 p.m. on weekdays, and during the weekdays between 12 p.m., 12 noon and 3 p.m. So we knew that we had to accommodate more donors, so we had to extend our working hours. Finally, during the pandemic, when there was a lockdown, we began to organize a lot of emergency blood donor drives. These emergency blood donor drives entailed us going to the homes of donors to pick them up. So we're going for pick-up drives, and when we were able to go to their homes, we had logistics teams going to particular bus stops to pick up potential donors for blood donations and to drop them back in their homes. Next slide. So these are the results. First of all, the first thing we got to realize was that we had enough blood to give to the people that needed blood and sister hospitals for the first 6 weeks of the pandemic. So we had no issues of inability to give blood to those that needed. The second thing is that we had an increase in the walking donors. If you look at that graph, it was an unexpected increase in our walking donors. The walking donors are the ones that do not need, they are voluntary donors, you do not need to remind them to donate, but they just want to do it. So we had an exponential increase in our walking donors, and this sustained the period of the lockdown. In conclusion, the measures that were taken were effective in mitigating the effects of the pandemic on the blood transfusion service, and so this approach can form a framework for intervention for future disease outbreaks in Nigeria and in similar settings. Thank you very much.
Thank you very much, Dr. Chikamaya Godori. Let's put your hands together for her. She only existed for just 1 minute, and that was amazing. Thank you very much. Yes, that's still good, trust me. All right, we have Professor Sunday Dabu next. Well, he's not ready. That's supposed to be a virtual presentation. Is Dr. Adebayo around, please? Is Dr. Adebayo around? Let's have her presentation if she is. All right, she's also not around. Do we have Titi Akosa in the house? Yes. Is she around?
Hello. Hello. Yeah, my presentation is scaled from 240 to 50.
So do we take a person who's ready online right now? Who's online? Who?
Mountain.
Let's have Dr. Mabubu.
Thank you. I'm going. Thank you very much. So, are you hearing me? Thank you very much. So, thank you very much. talk about our group. The operational research group in West and Central Africa is works on COVID-19. So my name is Mama Chako. I'm the scientific coordinator of the WHO World Platform Operational Research in West and Central Africa. So this platform was created to answer questions. What is the importance of research in response to Hello, are you hearing me? Good. So I was just saying that the context in which this platform was created is to answer to questions what is the importance of the research in response to the COVID pandemic in West and Central Africa. So to answer that question, there was an emergency meeting of the WHO and partners for the preparation and response to the epidemic in West and Central Africa. And some scientists proposed and the WHO accepted to create a group devoted to operational research to include operational research into the response. So this is how the platform research group was created. This operational research group is the first one of its kind in a regional WHO platform. So the platform of partners for the awareness and response to the COVID pandemic caused by the COVID-19. The general objective of the working group is to improve the response to COVID-19. The exchange of information on research in progress and to be developed, but also the transfer of knowledge. Specific objectives include to publicize current research on COVID in West and Central Africa, to promote analytic research on priority operational issues related to COVID-19, and to organize the transfer of knowledge related to COVID-19 and useful for it. So, we already run. Or we have regional health and here you have the different okay, 1 second and I'm coming. Are you hearing me now? Good. Thank you. So, is it good now? Great. So I just was showing you the different members. Case management, what areas of targeted by the operational research? Main areas are the laboratory monitoring and diagnostics. The vaccine, social and integration human right ethical consideration in emergency and in crisis. So our action by research project on COVID and organized by an area. So far, our achievement include monthly group meetings, and exchange a web-based platform, in several spaces, and we have 10 registered projects and 5 on selected public with critical reviews, which all focus on COVID-19 action, intervention in West and Central Africa. To go to the next slide. So I think any problem to go to the slide. Just give me a few seconds. Thank you. Okay. So you see the slide correctly? Okay. Thank you. So far, this was a webinar roundtable that we organized just Tuesday, which was held online, and which focused on the topics communication on vaccine from operation to target strategies. So this will have just last year Tuesday, and we have around 250 participants. So I would like to mention a little bit what our operation is in. So is to list and publish completed or ongoing research project on COVID-19. For visibility of the ACP through our website by publishing research project, books, and experts, promote exchange between researchers from different ACPs, and organize a transfer of COVID-related knowledge useful for intervention. So I would like to finish my presentation by WHO COVID platform as Central Africa. And I would like to encourage you to visit our website to see the different Central Africa, not just in French countries, but also in English countries. So the institution, if you want to register as an institution or partner or some as an expert, you can register. You can also register your project. Just accept mail, and then we will.
Okay, I think at this point we're really not getting anything of what he's saying. The audio is
any action.
Yes.
Related to. So I would like to thank all our partners here and my team.
The details about the website Dr. Babu just shared, you can always get that from the IT department. To get more information about his presentation, I apologize for not more audio quality. I guess it has to do with the internet connection on the doctor's end, but we had to take that presentation because he has been online for a couple of hours now. Is Professor Sunday Obilabu ready? That's also the virtual presentation.
Thank you very much. Good afternoon, everybody. I hope you've been enjoying the presentations. And today we are going to present to you a case study of our own Honorable Commissioner for Health, his own social media handles. And it's very important for us to bring this to your notice because we've used that handle really to really push out a lot of information, and that information has attracted a lot of people to his handles. Not just people in Nigeria, but outside Nigeria. And we've been able to have a lot of followers looking at how we started. We started with less than 100 followers. His handle was very not active when we started. But when we started giving information about his activities, anywhere he goes to tell people what he's doing, and then we also use it to publicize the strategies of the Ministry of Health and some of the new things, innovations that he's bringing into healthcare system in Lagos State. So, our Honorable Commissioner has a social media presence. He has a Twitter handle, he has a Facebook page, he has a LinkedIn and Instagram. Those are the 4 major social media platforms on which he's been interacting. So we are going to be looking at his own Twitter handle because that is where we have a lot of people interact with him. So social media has played a significant role in mediating communication about COVID-19 from the onset of the pandemic in China. As a tool of communication, it has provided huge information access to Lagos State residents and Nigerians at large during this pandemic. As the COVID-19 became virulent with uncertainty, social media platforms, which are easily accessible on mobile phones, serve as the hub of regular updates. And when we are talking about updates, before we started showing updates, we started preparation in Lagos State. And all his preparation activities were always on his social media handles, from Facebook to Twitter to Instagram. I think I should go to the next one. So this is his social media presence. If you look at it, we started with the activation of the EOC, which was well covered in this handle. And we continue to move. As we move from the period of preparation to the period of the first interface, these are some of his sample tweets. We moved from preparation to the ICS, and it was a whole lot of activities, and all these activities continue to go on his handles. Also, after the preparation, we started having some videos made by the Ministry of Health, and those videos went viral. The first of our videos went viral, and it attracted a lot of people from all over the world to that handle. And so we started having a lot of followers. So by the time we had the index case, look at the timeline, we had in December 2019, and by the time we moved to January, I think we had the ICS sometime in ending of 23rd of January, if I'm correct. And that's about a month before we had the index case. So everything was reported, and as it was being reported, people were following that handle. And by April, we had the highest follower. We had 84,000 followers in the month of April, compared to all the other months that we have started creating awareness. If you look at it, we have community spread versus new followers. Maybe let me just shorten it. Let me go to another. No, wow. Sorry. Who removed that? Why did you remove it? Don't go to conclusion, please. Can you give me the monthly one? go on.
We have 2 minutes more, please.
Don't worry. Go forward, please. Next. There's another one there. This is not it. There is the one for the monthly one. It's not there. Okay, let me just speak to it. We have the highest followers for February, for April, the month of April, and there are many reasons for that. Before April, in February we had the index case, and by February a lot of people wanted more information to know about COVID. A lot of people didn't understand what the COVID is all about. So his hand was that natural place for people to go to get that information, because we have started turning out information about COVID. We have also turned out advisories about COVID on the timeline, and people were looking forward to it. So by the time we were in March, the Alpha case happened, and we published it, and it drew a lot of attention that if one person could test positive for COVID at a very big gathering, where we have
exactly 30 seconds more.
Yeah, we had a lot of Nollywood people. Then it means that this thing is very real. So we had a lot of people coming in on that timeline. And after that, we also had what I call a spillover, where a lot of people were under lockdown. So they had time to check that handle. After checking that handle, we also had television stations using that handle as a newsmaker during their general news, maybe at around 9 o'clock news or 10 o'clock news. So it continued to attract a lot of people to seek true and genuine information from his handle. And let's go to the conclusion. Don't worry. Can I get to the conclusion slide? So, in summary, the role of social media in COVID-19 Lagos response has been impactful in the handling of the pandemic. So far, social media channels have been used to deliver the following: sharing real-time updates, creating awareness through hashtag, prompt dissemination of updates, platform for providing advice and helpline online, and prompt attention to emergency situations. And the leader of the social media team for the Honorable Commissioner is the Honorable Commissioner himself, because he also posts with his hands.
You are a sounding round of applause.
All our team, please be outstanding. Baby, stand up, let everybody see the social media team. Abigail, Tosin, where are you? So these are my team.
Very persistent. But the whole idea is that the social media is a mechanism for monitoring real time. That's the Coco, that's what the point that you try to make. Is Dr. Adeba around? Okay.
in areas like Ibejuleki. Total student strength was about 350 and staff 100. Things we noticed there, they had a staggered resumption of students, so they didn't all resume at the same time. They had a standard school clinic with trained nurses on ground, and they had participated in training by the Ministry of Education, Department of Educational Policy prior to reopening, which was one of the prerequisites for reopening in Lagos State. And the school also had capacity for virtual learning, both on-site and off-site. Now we use the following case definition. I will not go off with that. Now, if I describe the index case was a 14-year-old female student, a boarder in year 10. The student had presented with a history of headache exactly 7 days after resuming school. It did not respond to normal antimalarials or analgesics, and parents came to pick her up. She had a COVID test done in a private facility, an accredited facility, and she was found to be positive. We received notification from that facility, and then we swung into action immediately. Methods: we reviewed the clinic register, conducted case investigation among staff and students. We listed all the contacts, classifying them into high risk and low risk contacts based on proximity. So those considered to be high risk were her roommates, her classmates, the actual harm, those she went to dining with, and we also got a list of her close friends. We collected samples for PCR testing. It wasn't a very large school, and because it was the first school outbreak, we disclosed for most of the students, particularly after we had a 50% positivity rate in the first set of samples taken. And then we analyzed that data by person, place, and time. Now, our qualitative finding, we said, from our investigation of other cases, this is not the index case now, because we conducted investigations and interviewed every single student on site. And we found out that we actually had a year 12 student who presented with symptoms in keeping with COVID. She had fever, a cough, sore throat, fever was high rate associated with chills. At the time they resumed, she had those symptoms. And we found out that her sibling was in the same class and in the same room as our index case. So we were suspecting that that could have probably been the primary case to the best of our knowledge. We also found out that several students, a few students had been sent to following presentation with febrile illness, but the healthcare provider had a low index of suspicion for COVID-19. With regards to we found out that they had adequate hand washing stations. However, there was poor compliance with mask use among staff and students, and suboptimal social distancing even within the limits of what they could actually do at the school. Now, when we look at socio-demographic characteristics, we looked at them by students and by staff. Among the students, 48.4%, 151 were female, and just a little under that were male, while among the staff, 31% were female, while 7% were male. Looking at their locations, for students on-site in boarding, but they also had staff quarters within the school. So we had, that's a mistake. So we had actually 78% of them being in school, that among the students and 54% of the staff. Now this is the age distribution among the students and among the staff. Now when we look at the clinical characteristics, in all, we had a positivity rate of 2.3%. It was 41% among the students and 46% among the staff. Now with regards to symptoms, only 27.8% of those that were positive were actually symptomatic. None of the staff reported symptoms. But then the methods of data collection was different. In the students, we interviewed them. But because of time constraints, because of the distance of the school, we actually collected online information from the staff. So this could have actually affected their responses. So we had 39% of the students presenting with symptoms, while 58% were asymptomatic. And we had this data for about 2.3%. And if we look at the common symptoms, because we wanted to describe this epidemic, found out that 10% of the students complained of a runny nose. That's the first symptom. Several of them had 2 or 3 symptoms. Runny nose, cough, fever, sore throat, headache, and new loss of smell were the first symptoms that the students presented with. So this is just distribution of positive cases by age and by sex. So we see that we have the greater burden amongst those that were 10 to 14 and then 15 to 19 years of age. Now, we looked at positivity rate by class because we realized that that student was in year 10. So in year 10, we had a positivity rate of 54.7%. But in year 12, where we suspected that we had our primary case, we actually had a positivity rate of 70.8%, which further buttressed the fact that that might have been our positive case. Now, when we looked at the factors, there was no significant association with the sex, but the association with the class the student was. And then, funny enough, we found out that day students were also more likely to be positive. Day or boarding, because we operate a system whereby some students do weekly boarding, and then we also have day students. But one thing we found out later is that several of them had decided to go back to day after reviewing for boarding. So we don't know whether that might have been because they were sick or something. So that would have been a confounder. Now, what did we do? Immediately, it was a joint team. We had members from the EOC, surveillance, IPC, we were all involved. And the Honorary Commissioner was on our neck every step of the way. And the LGA team was also on ground there every day. So there was supervised isolation of confirmed cases and quarantine of close contacts. Then there was daily follow-up by the LGA DSLO. And there was restriction of movement during the active period of the outbreak. So day students reverted to virtual learning. In the school too, they also reverted to virtual learning with students learning while in their hostels. We ensured that there was provision of home-based care packs for all positive cases. And there were several interactions with parents and staff through Zoom platforms to provide updates and address their concerns. In conclusion, although the school had adequate hand washing stations, compliance with mask use was poor among both staff and students and was not enforced by staff. All positive cases and contacts successfully completed the supervised isolation and quarantine periods respectively. Our recommendations are that there is a need to establish linkages between schools and LGA authorities to facilitate prompt case investigation and testing, which is already ongoing. And we also noticed that we need further training of staff, because we noticed that most the trainings that we have are targeted at teachers, but we also need to target healthcare providers within school clinics, particularly for boarding schools. And we need to reinforce infection prevention and control measures, such as wearing of masks and social distancing. Sorry, I acknowledge the following. Thank you very much.
Thank you very much. At this point in time, I want to give ourselves a huge round of applause. We've been here for 3 days, and there's no need for us to recap, but we've been touched and we've experienced what this program has been able to share with us. But you know, you can't have this program without people who have provided some funding and some support and some help. So as we round up this program, we want to especially recognize our partners, co-sponsors, and I'll call them out one by one. If any of the representatives are here, please come. Zenda Consulting. As I call them, please give a round of applause. That is Carter Bates Logistics. Please come out of it. Stand up for some representation, and maybe you will just give a word on behalf of the other sponsors. There's also Ikaba, Block 10. Any representative, and then Peter and Jane.
Consortium has ensured the efficient dissemination of information through the use of technology and inventory management. The leadership role of His Excellency, Mr. Governor Balaji Sanwo-Olu, in managing and planning the program of justice. He's able deputy incident commander, Professor Akin Abayomi, and the entire health team of the state. We pledge our continuous commitment to support Lagos State in ensuring that it remains at the forefront of biosecurity and medical advancements in this field, and that most importantly, we succeed in its mandate to protect the lives of the citizens by containing and combating the spread of infectious diseases. Finally, I would like to congratulate the organizers of this successful event as we look forward to attending subsequent ones. Thank you very much.
Thank you very much, sir. Yeah.
We've got multiple bases across the state, but our main office is
in just one word, what would you consider, how would you consider your experience operating in Lagos?
It's been very enlightening. Initially, it was difficult for everyone to speak pretty static. Pandemic brought out the best of most of us, and I think that when we came to calm down, we wanted to go.
And you look forward to, well, we hope there are no more pandemics, but there are going to be several opportunities for.
The truth is, as one of my learning colleagues said, why wait for the pandemic, or why wait for the crisis? The truth is, we've got the opportunities to start fresh, and this time, I pray, well, we're already on the right track to get everything well.
Thank you, bro. Round of applause for him. Dr. Shea. At this point in time, we're gradually getting to the end of it. I'd like to call on none other than the Honorable Commissioner for Health, Professor Akiabayo. In a way, he's going to close this conference by giving us or sharing us his thoughts and takeaways. That's how they put it. What do we take away from this conference? We've had 3 days. We've discussed everything along the spectrum. Management, the science of law, the organization, the collaboration, the standards we try to set, the whole raft of issues. But what do we take away? So I'd like to respectfully call the Honorable Commissioner, Professor Akiabayo, to come to the stand and give us his parting remarks and the takeaway. Thank you very much, sir. Round of applause for him.
It's almost evening, so good afternoon, evening, everybody. These I can see are the diehards, the people that are left here this evening. So very committed to the cause. So it's always a sad moment for me to close a GET conference. This is the 6th conference we've organized. Because the meeting is usually very rich. It brings a lot of people together. It consolidates relationships. Unfortunately, this year, because we're in the middle of the pandemic, it has been an unusual conference. We've done a lot of it by virtual communication, and so it has lacked something. It has lacked that family or biosecurity experts that normally come together every year all over the continent, South Africa, Kenya, and from abroad. We normally have a full house of international biosecurity experts on the continent of Africa once a year for what's becoming the iconic biosecurity meeting of the continent. We've been to Ghana, we've been to Sierra Leone, we've been to Senegal. This is the 3rd meeting we're having in Nigeria. We had one in Lagos in 2016, and we had one in Abuja. It was the meeting in Lagos that really consolidated the biosecurity roadmap for the state. And it was at that meeting that we really started to map out what we were going to do to make Lagos more resilient and less vulnerable to biosecurity threats such as COVID-19. And I think you will all agree that as a result of these meetings, there has been so much information transfer to different countries, to different health professionals that are interested in One Health and biosecurity. And as you can see, biosecurity is multifactorial. It brings climatologists together, it brings scientists together, it brings doctors, social scientists, civil society people, lawyers, security officers, psychiatrists, because that's just the nature of biosecurity. The nature of biosecurity is to ensure that everybody is safe in the environment and there are legal ramifications, there are social consequences, there are security issues, there are health issues, and there's a whole environmental, climate, agriculture. So it's one of those meetings that's very interesting because it brings all kinds of different subject matter experts together to talk about how to ensure that we continue to protect our biosphere, and if there is an aberration in our biosphere, which is a bio-insecurity, that we correct it. So we've heard talks from different fields of expertise. It's been a very rich experience for you, I'm sure. At the end of a GET meeting, we normally prepare a declaration or a position. And I'm sure that at the end of the time, when the rapporteurs are able to put things together, we're going to come up with a position paper or a 2020 declaration, which will inform policymakers of what we feel they should focus on and prioritize for the coming year. So we're going to decide on the theme for 2021, and we are going to decide what side activities are going to happen. We didn't have much side activities today during this conference because of the size of the conference. It's probably the smallest face-to-face conference we've ever had because of COVID and isolation and travel restrictions. But I promise you that in 2021, when we've all recovered from COVID-19, the economies have returned to normal, people are able to travel again, and we're going to have a very big meeting to look back properly at how we managed COVID-19, the lessons learned, and what we're going to do moving forward to protect the continent of Africa from future biological threats. So on that note, I want to thank a whole host of people. First of all, I want to thank the chief host of this meeting, who is our governor, Mr. Babajide Sanwo-Olu, the incident commander of the Lagos State COVID-19 response. I'd like to thank the entire cabinet, several members of the cabinet. They graced the occasion. I'd like to thank the GET Consortium for working very hard to put this together. All your team members, you're getting larger and larger, your footprint is expanding. The fact that you managed to have this conference right in the middle of a global pandemic is testimony to the hard work and the commitment and the resilience that your organization displays. I'd like to thank the Ministry of Health, Lagos State. This is a partnership between GET and the Ministry of Health, Lagos State. Lagos State has always been embedded in this activity. Even sometimes when this conference moves out of Nigeria, you have a very large contingent of Lagosians following the conference to whichever city it goes to, making up almost a third of the experts that are attending the meetings. I'd like to thank our donors who have gracefully given of their time and their resources because of their interest to see that biosecurity strategies are developed. Thank you very much. I'd like to thank all of you that have come to participate, all our visitors from Guinea, from Rwanda, from other countries. I'd like to thank my colleagues, my fellow commissioners that have come from the other states to come and support this meeting. Many couldn't make it because of the circumstances in the country, but they've all sent their goodwill messages and hope that this will be a very successful meeting. Finally, I'd like to thank the youngest biosecurity experts in the world. Kept us entertained. And to the masters of ceremony, you've done a wonderful job. You know, it's not an easy thing to be a master of ceremony. I've tried it once or twice, and I didn't do very well. Because you have to combine both a deep knowledge of the subject matter with charisma, with organizational skills. The conference is always fluid and dynamic, so things are always changing and happening, and you are always in a position to bend and duck with the changes. And from what I've seen, you've done a fantastic job. Your commentaries have been excellent. The way you've charmed the crowd, the members, I think both of you have just done a wonderful job. We hope to be able to attract you to the next meeting in 2021. I just want to say one final thank you to a representative of a good friend of mine, the National Security Advisor, Brigadier Babagana Monguno, who could not come. We were classmates in King's College. I saw him for the first time only a few weeks ago after a very long time. Of course, he's a very busy man and he couldn't come, but he sent a very able representative by the person of Dr. Damisa, who is seated here. Thank you very much for gracing this occasion. I would like to remind you that Damisa, in your language, means leopard. Is that correct? So your other name is Dr. Namate. So on that note, to all the camera, the crew, all the support services, my team, the artists that came to display, my friends, my colleagues, the DJ, play your music very loud, by the way, and all the support, security, thank you very much. I appreciate your presence, and we'll see you again in 2021. Bye-bye.
Thank you very much. who is the COO of GET, Dr. Overdoing. Thank you very much.
Yeah, good afternoon, ladies and gentlemen. The only thing that is constant in my mind is once you start something, it has to be an end. And I don't want to go with more stories again. Probably everybody except himself. So, let me use this opportunity to thank Professor Kamayo for what and all he has been doing for GET as an organization, and for what he did for us this year to make sure that this conference is a success. Like he said, it's not easy putting up such a conference. It's not a time like this when everybody is very busy. But it was there day and night to make sure that this conference is a success. And on behalf of every member of GET and everybody that is present here, Professor Kamayo, thank you very much for what I did. A round of applause for you, please. Next year conference will be coming up. We're going to take a decision on that very soon, and we're going to communicate it to everybody. So, those, I'm saying thank you for those that are traveling from Rwanda, from Kenya, from the north. Thank you for coming to Lagos. We appreciate you. And I wish you safe journey back to your country. Enjoy the night, catch up for see Lagos in the very proud place. We'll see next year by God's grace at the 7th conference of Global Enterprise Leadership Network. Good night. Bye.